Okay, so as you were just hearing, there are three of us sharing this session with related slides. So we're talking around the same theme. I'm going to give a bit of background first of all and lead you into the study that we're starting in Oxford shortly. So I'm a clinical lecturer. I work at the John Radcliffe Hospital in Oxford and also for the university in paediatric infectious diseases. And I'm going to talk a little bit about the BCG vaccine and some work around some new potential observations around the effect of BCG. So tuberculosis, as you'll all be familiar with, is a huge worldwide problem. It affects potentially up to a third of people worldwide are infected with latent tuberculosis, so a form of the disease that can reactivate at almost any point in subsequent lifetime, and causes several million cases of new clinical disease each year. In the UK, the problem hasn't gone away, and I'll show you some data on the epidemiology in the UK in a minute. And as you'll be aware, in adults, primarily people think of chest disease with tuberculosis, but it can affect almost any bit of the body. And particularly in children, we worry about tuberculous meningitis, which can be quite a difficult disease to pick up and can be a devastating outcome in children afterwards. And it's caused by Mycobacterium tuberculosis, one of a group of organisms which are quite difficult to diagnose, but also to treat. They live inside cells of the immune system. They have various mechanisms to evade the immune system, and they require lengthy treatment with multiple drugs to rid the individual of the disease. So this is the epidemiology over most of the last century in the UK. So declining rates, some blips around the two world wars, and then the introduction of effective chemotherapy and then vaccination. And recently the incidence has started to increase again. In the native UK population, because the disease rate was falling, BCG was the programme for immunisation was changed around 2005. So we previously had a schools programme where everybody was vaccinated as an adolescent, and given what is a live attenuated vaccine. So it's made from Mycobacterium bovis, a related bacteria within the same group, and this has been attenuated, been weakened by multiple cycles of growth in the laboratory until it's less virulent. And it's given, as you'll be aware, by intradermal injection, so it's slightly different from most of the injections that we give as part of the routine vaccination schedule in the UK. And it also differs in that most of its effect seems to be through T cells rather than by producing antibodies to deal with TB. So currently the programme in the UK for immunising relies on neonatal immunisation. We give routine immunisation to all neonates in certain areas which have a higher rate of TB in the UK, but we also target it to individuals who are born to parents who are born overseas in high-risk countries or grandparents who are born in high-risk areas. But it's not a routine immunisation at the moment, and the high incidence in this situation counts as more than 40 cases in 100,000 people per year. There's some debate over the effectiveness of, or there has been historical debate over the effectiveness of BCG. So looking at a large number of studies that have been carried out, this shows you each study listed separately here and shows the effect of BCG in preventing tuberculous disease. All the dots to the left of this line down here show that the vaccine is effective in preventing tuberculosis in that individual study. And you can see that the majority of studies found that BCG is effective, but quite some variation. And these studies are listed according to geography, so the more northerly countries compared to those close to the equator. And you can see that there's a suggestion that BCG is more effective in countries further away from the equator, and there are various reasons for that as well. And more recently, this is a paper from this year looking again at this question, showing that broadly there seems to be a significant effect of using BCG against tuberculosis. And so this is showing a reduction in disease of around 80% in the studies that have been included. So that's BCG's effect against tuberculosis. But more recently, there have been observations in a number of studies suggesting that potentially BCG vaccination could have an effect, a more general effect on child health and morbidity and mortality. So this is a series of studies that have been carried out, many of them from a particular research group led by Peter Orbe in Guinea-Bissau, suggesting that giving BCG can affect the mortality in infants and young children in what's a high-risk, high-mortality setting, but over and above the effect of reducing TB disease. In addition, they've also noticed that another live vaccine in the schedule, the MMR vaccine, may also have mortality benefits, and other groups have also noticed the same. And that the sequence of vaccination may be important. So giving a killed vaccine subsequently could have an effect to reduce the extra benefit of live vaccines. This is an example of the data from one of their studies of about 5,000 children. Perhaps one of the most striking things in this graph to start with is that this is survival risk or survival probability in children up to 6 months of age, and there's a huge mortality rate. So 5% of children have died by 6 months of age. But there also appears to be a difference between those given BCG and those that did not receive BCG. And that's greater than the effect, that can be accounted for by TB disease on its own. Another study that they carried out, and this was a randomized study. This graph is the other way around, really. This is looking at mortality data cumulatively over time, and this is up to the first year of life. Also showing that if you give low birth weight babies BCG, and these babies wouldn't normally receive BCG in Guinea-Bissau, they were excluded from the routine immunisation, that again survival rates seem to be improved by giving BCG to these infants. Now there are a number of problems potentially with these studies. They're not carried out in a well-resourced country such as this, so they don't have the trial infrastructure and the ability to gather as much information about patients. Most of these studies are non-randomized studies, often observational and done after the event rather than planned beforehand. And they're small studies, and comparing data from slightly different study designs and slightly different populations is difficult. And often there is no data about what killed children in those children that died during the study. There are significant risks of bias, so there's a big factor of socioeconomic status. Those parents that have more money or live closer to hospital centres may be able to get their child vaccinated, and those that don't are unable to. And that itself has a big effect on the child's risk of mortality. There's a survival bias inherently in that those individuals that survive to follow up we have more information on, and we may be able to record aspects of their condition that bias the results subsequently. And in particular, the immunisation records are kept in Guinea-Bissau and many other countries by a handheld record that the mother carries. And that's often destroyed or lost after a child dies. And that can give the impression that when a child dies, it hasn't been fully immunised because there's no record of the immunisations that occurred between study visits once the child's died. And clearly there's a question about the relevance of important data for developing countries in the schedules that are used in developed countries. But I guess an important question is whether this effect could be plausible. So if the observations are accurate, is there an immunological explanation for what's been seen? Potentially cross-reactive responses could explain some of what's been seen. We know that antibodies are produced against particular diseases or immune stimuli, of which vaccination is one, but they can cross-react. So antibodies can be produced against multiple organisms or multiple infections from one immune stimulus, so a polyclonal response. And a similar effect is observed with T cells that can be stimulated against multiple infections from a single stimulus. The immune system responds in different ways to different stimuli. So different arms of the immune system can be activated with each individual stimulus. And it seems that live immunisations often skew the immune system towards one particular aspect of the response, and that may differ from killed vaccines. So that could be important in changing the way the immune system responds to the next stimulus, the next infection, or the next vaccination. And that's where the sequence may be important. The last vaccination that was given could have an impact on how you respond next time. And then there could be a direct effect of giving BCG at the same time as other vaccines are administered. So BCG is often given at birth, so often separated from the time of the of administration of other vaccines, but sometimes it's delayed or given later because of other problems, and can be given around the time of immunisations with other routine vaccines. So it could have an adjuvant effect, an effect of increasing the inflammatory response around the time of the second vaccine and enhancing response to that other vaccine. So does this matter? Well, clearly it's of significant importance to the developing world, to countries that use BCG in a high mortality setting. This could be this could explain some of the observations that have been seen, and could be a relatively cheap intervention to improve childhood mortality if we understand the effect that BCG is having on mortality. Simple changes such as the timing at which BCG is given could have a large impact. That's also of relevance in the UK. So as I say, we plan to give BCG after birth, but often that's delayed by several weeks. And we don't really know whether giving BCG at birth or giving it at 3 months, or even later than that, has an impact on outcomes that we would notice in the UK or on immunology. There have been some studies looking at whether in low mortality settings there's a change in the rates of hospital admissions. So a readout really from the risk of infectious diseases or the severity of infections experienced subsequently. And some suggestion that the rate of hospital admission might be reduced by the use of BCG. And clearly it's important for us to understand the effects that vaccines that we're using in the UK are having on immunology, the immunology of the response, and that may influence subsequent vaccine design and vaccine schedule design. The World Health Organization is aware of the importance of this area and has set up a working group which was convened last year to look into the existing data in this area and to make recommendations for future research based on the studies that have been carried out so far. And we were interested in Oxford to look into this area further. Clearly, we are not in a position to examine mortality, and we're not in a high mortality setting here, clearly. But we can look at other aspects of the effect of BCG, so the immunological aspects. So we have thought about setting up a prospective randomized study looking at different timings of BCG administration to children in the UK, and thinking about whether we can look at changes in the immune response to other routine immunisations given in the schedule. And as you'll hear, we're particularly focusing on Men-C because there's no data out there at the moment on the difference in Men-C responses with BCG or without. And looking at both the amount of antibody that's produced after immunisation, but also how the levels of antibody persist over time, and whether those antibodies are effective, whether they're functional. And then we have the ability to look at other antibody responses to other routine vaccines given in the UK, also other effects of the immune system in responding to vaccination, so the immune messengers that are produced, the cytokines, and also cellular responses. And then we're also interested, as you were hearing, in some of the gene expression readouts that we can now look at. So we're going to look at the gene activation before and after BCG has been given and see if that gives any explanations as to what has been observed. And we've received some funding to carry out a study from the Academy of Medical Sciences. And I'll now hand you over to Danielle, who I think is going to talk next, to tell you a little bit about how we've progressed this into a study. Thank you.
So, as Sarah introduced me, I'm Danielle. I'm the Canadian that you may hear if you've called into Vaxline. I'm also one of the senior research nurses with the Oxford Vaccine Group, and that's really my main role. And so today I'm just going to talk a little bit about, very briefly, and it may be a bit intense, about the research process. So David was talking about an idea regarding BCG and Men-C and how we really take that idea and take it through to a clinical study. So I'm not sure how many of you are really familiar with clinical trials. Just simply put, a clinical trial involves any research involving human volunteers, and it's basically intended to add something to our medical knowledge. And mainly they involve one or more health-related interventions, for example, using medications or, in our case, vaccines, to evaluate their health outcomes on humans. Now, if you're not really familiar with clinical research, there's a lot of jargon that gets thrown around, and sometimes it can get really quite confusing. I won't go through all these terms with you. Carrie will discuss a little bit about what a randomized control trial is. So I just wanted to discuss briefly a little bit about the phases of vaccine development. Now, before you do any trials in humans, you have to go through two distinct phases. So one in a lab or in vitro, where you're really testing out your vaccine in a petri dish. And then you have to go through what's called the preclinical trial phase, where you're testing out your potential vaccine in animals. And those two phases really need to identify initially, potentially if it would be safe to go on to human trials, and if you think it could be effective. Now, as Andy outlined as well, there are different phases of clinical trials. Really, when you go through the phases, you're looking at risk and size. So as the triangles say or show, your risk is inversely related to the size or the scale of your trial. So in phase 1 trials, you're really trialing in the smallest group possible, and you're really looking at the safety, for example, the safety of your vaccine. You want to identify side effects mostly, and sometimes you would look at how effective your vaccine, for example, works. Phase 2 and 3 are much larger trials. You're really looking at, for example, your vaccine in its intended population. So oftentimes, phase 2 or 3 clinical trials involves testing out a new vaccine in, for example, children, because that's where you would really want to use your vaccines. And on top of that, in those trials, you're looking at your safety, but you're really looking at how effective your vaccines are. So you're looking at, do they produce an antibody response? Do you think they would produce protection? And then you get your phase 4 trials, and these are really done after you've licensed your vaccine, and potentially you've given your vaccine to a wider population. So this is a study right now that we're looking at with the BCG and the Mency vaccine that Carrie will explain. So there's quite a heavy process that goes into, as you can see, with conducting a clinical trial. You really start with an idea. Sometimes it comes out of David's brain or Andy's, for example. And from there, you want to develop a proposal so that you get funding for your trial. If you are successful in getting funding, what we do is develop a protocol. And basically, the protocol outlines what your objectives are of the trial, what you think your outcomes will be, and it outlines really how you would conduct your trial. And from there, you would also develop study documents. So sometimes you get letters through your surgeries regarding somebody taking part in a trial, and that's the kind of things that we create. A part of this as well, before you can recruit anybody or do anything, you need to get approval for doing your trial. So there's different ways of getting approval and different bodies which you need to get approval from. And depending on what you're doing in this study, so these 3, you may need approval from just one or approval from all 3. So the MHRA really is involved with what's called investigational medicinal products. So any trial that's involving a medicine or a vaccines needs to be approved by the MHRA. For any studies done in humans, to ensure that your study is ethical, you need ethics committee approval. And then for any trial that involves using NHS patients or NHS services, you would need, of course, your NHS trust approval. So really, once you gain all your approvals, you can start recruiting for your trial. Now, recruitment can take many different forms depending on the population you're looking at. So we sometimes mail out through our electoral roll for adult studies. We contact the NHS Child Health Database and mail out through them. Or you can put up posters, things like that, to recruit for your studies. Once you have people that are interested in the studies, really you need to obtain informed consent for them to take part. And you really need to as well check that they're eligible to take part. From there, you conduct your study visits. Now, in terms of our study visits, like I said, most of our studies involve vaccines, but sometimes our studies involve carriage of a particular bug. And studies can really last from a day to a few years, depending on what you're doing. You can collect many different kinds of samples, for example, blood, nasal swabs, things like that. And you can give a variety of different vaccines or just one vaccine, depending on your trial. So after you've done all your study visits, you really want to analyze all the results, for example, results that you get from blood samples. And you want to put them together and compile your results in order to produce a publication. And really, in the end, when you produce this publication, you want to make sure that it affects practice in some way. So within this research process, I don't know if a lot of you are familiar with the role of the research nurses. It really is such a key role, and it's very different what you would do in clinical practice. we're quite involved throughout the entire process of the study. So setting up the study, so we help write protocols and study documents. We manage the study, we train staff on the study as well. We're really the key person or key individuals involved with recruiting, consenting the participants, immunizing, taking samples. As Andy mentioned, we also do challenge studies with typhoid and paratyphoid as well. And we really are the main contact with the study participants. So we build up rapport with them, we educate them about vaccines. And because we spend so much time with them, sometimes a really anxiety-ridden situation like giving a vaccine or taking a blood sample, we can kind of make it a little bit more bearable. And of course, like days like today, we do vaccine education, and we can be involved in publications as well. And really, the main message is that we're such a key, we play such a key role in what we've done. And Andy's already shown this slide, but because we're really the ones on the ground doing the visits, being involved with the participants, we can really affect the way a trial goes. And as Andy's outlined, we'd had the opportunity to already affect some of the routine immunizations already used in practice. And we're continuing to do studies into new vaccines. Like he's outlined, MenB, we've done many studies in vaccines, which nurses really play an important role. And I mean, the main message from all this is that we produce these we don't produce these vaccines, but we trial these vaccines so that they do have a positive impact on practice and policy development, especially in the UK. And if you happen to be interested at all in any of the research that we've done, we do have a very nice publication section on our website. We also have our recruiting studies currently if you're interested at all in those as well. So I'm going to hand over to Carrie, who's going to talk to you a little bit about one of our trials we have going on at the moment.
Okay, hi, I'm Carrie. I'm a research nurse and I've been working at Oxford Vaccine Group for about 1.5 years now. Prior to coming here, I worked in the community with children in a variety of different settings. So what we're doing is focusing in specifically on the interaction between BCG and the meningococcal C immunisation. For ease of use, we've shortened this to BAM study. So if you hear of anybody talking about the BAM study, this is what we're discussing. So now the next slide is going to be very busy, but hopefully it'll become clear. Now, the study, what we're hoping to do is recruit 30 newborns in their first week of life and in the Thames Valley area. And these are babies that are not routinely due the BCG vaccination, okay? Now these 30 newborns, we're going to be divided into 3 groups. And Danielle shared with us some jargon that came up earlier in Bubbles. And this is an RCT, so it's a randomised controlled trial. So it just means that every participant's got equal chance of being on any of the treatment arms. It's a phase 4 study, so try and remember what Danielle was sharing, which means that the vaccines that we're using are fully licensed. So we're just further exploring how these vaccines are working. It's a unblinded study, which means that everybody knows, all the participants know which treatment group they're getting. And it's also a pilot study, so we've got quite small numbers on this, and so we're hoping to recruit 30. Now, this study's been through all the rigours of the research governance that Danielle shared with us, so it's had to go through all the processes of getting the approvals that are needed and to get to this stage. So, what we're hoping to do is that with the children that are recruited, the study period is from the first week of life through to 13 months. Okay? All the children get all their routine immunisations, but the groups divided into 3. The first group get the BCG at birth. The second group get the BCG at 3 months at the same time as the meningococcal C. And then the third group wouldn't get the BCG at all, or they do have the optional OCC. We have got an optional BCG if at the end of the study the parents decide that they'd like their child to have the BCG. So we'll be comparing these 3 groups of children. through the use of there's 5 timely blood samples that we'll be taking throughout the period of the study. And we'll be looking at these to discuss, at the end of David's talk, he was saying what we'll be looking at. So we'll be using these to look at the meningococcal C immune response, so the amount of meningococcal C specific antibodies, the amount of them, how good they are, how effective they are, and we'll be looking at, like Liz shared with us earlier, we'll be looking at other cellular responses, and like Andy was talking about as well, we'll be looking at potential the genes that are switched on and off during this process, and we'll be comparing between the group that had BCG at birth, the group that had it at the same time as the first meningococcal C vaccine, and the group that didn't have it at all, and we'll be comparing the analysis of these results to look through them. So, how to get the study from paper into practice, as Danielle shared, is quite a big role really that the research nurse can play. And one of the main challenges for this particular study was, how are we going to recruit babies in their first week of life? And this is something that needed to be considered very early in the process, because we need to know where and who and when and what kind of information to give people the time and the ability to have the appropriate information. So this needed to be considered way back in the process when we were putting the protocol in, because how we go about recruiting is also included in all the ethical approvals and things like this, which is really important. So what we felt was important was that at this particular time, it's a very sensitive time. You're potentially very vulnerable. It's potentially a very chaotic time. And so we felt it was important that people had the information prior to this, so therefore in their pregnancy. And so what we've done is we've cast the net very wide, really. We've advertised in GP surgeries. We've asked them to put up posters in antenatal settings. We've sent out information with the 20-week ultrasound invitations that people get. We've Oxford Spire's midwifery-led unit up on level 7 of JR have been involved in helping giving out information as well. And these are to mums that are 36 weeks through to term. And also we've had it advertised on our website and on Osprey website at all. That's the Oxford Safer Pregnancy and Research Alliance have put it on their website as well. So what we're doing was casting the net very wide, and this comes back as well to it being a pilot study, because this challenge is something that we can learn from. So we can learn about the feasibility of how this study can run by, when people reply, we're going to be collecting the data about where they've got the information from originally, and we'll be painting a picture of where you can most effectively and efficiently recruit people, and using that information in any further studies that need to recruit babies of this age. So really this whole study has been a journey, in a way, from the interesting observations that David shared with us earlier that have come out from studies in developing countries, right the way through a series of stepping stones, really, to potentially improving vaccine knowledge and potentially positively impacting on clinical practice. And it's quite encouraging, really, that as a group of professionals, as a group of health professionals, we can have at certain points along this journey have an impact, and this can have a significant and a valid impact on society. If you're interested in any more information about this study, our website's on the handout, but also if you just Google Oxford Vaccine Group and then look in research and in recruiting studies, and we're at the top. I think that's because it's alphabetical, but we're at the top, and that's where I'll finish. Thank you very much.